Hi, everyone. Welcome back to Tumor Talk. This is a collaborative effort between Lenox Hill Neurosurgery and the Journal of Neuro-Oncology, where we like to present recent publications in the journal and highlight the authors who kind of constructed them and talk about the results and the relevance of these studies. And today we're pleased to have Kristen Huntoon with us, who I believe is currently at MD Anderson. And she's going to talk to us. Why don't you go ahead and describe the paper and kind of dive right into it?
Okay,
Appreciate you being here.
Thank you for the invitation, and thank you for letting us discuss this manuscript that was recently released in JNO. So I think that I've seen in previous ones what initiated the study. So I was doing some cases with Dr. Elder, who's one of the major brain tumor surgeons at OSU, which was my previous institution that I was at. And we were noticing that our post-op MRIs seemed like they may be overestimating the amount of tumor, or at least what we felt like we had taken out during the course of the procedure. So this is just an example that's also in the paper, but to just highlight, I'm not sure everyone's educational level that will be seeing this or watching the recording, but this is 4 different axials images that are FLAIR. And so the tumor is this image or the lesion that's in the left temporal lobe. And we usually use FLAIR to look at the low-grade gliomas, both intraoperatively and postoperatively to determine the extent of the resection. Some people do use T2 in addition, but I think FLAIR is primarily the one that's used most often. So panel B is the intraoperative MRI that was taken when we felt we had as much or as gross total resection as possible. C is an image of the lesion after resection, so post-op. And we usually like to do our post-op MRIs within 24 hours of resection. And then panel D is a late post-op. So usually what the neuro-oncologist would like to consider their first time point. And we just find that in this study, at least being 3 months. So to ensure this wasn't an anecdotal thing, we had discussed actually looking at this with multiple patients. So it was a retrospective study. It was over the course of 3 years since 2015, which was when we had our 3 Tesla intraoperative MRI put in place at OSU. There were 70 patients that had a low-grade glioma resection during that time period. And then to ensure that what we were comparing was truly apples to apples, we wanted to ensure that all the patients were undergoing a gross total resection, or at least that was what was attempted. Like I mentioned earlier, we wanted our post-op MRIs within 24 hours just because some of the blood products and some of the scarring that can happen after 24 hours may alter the imaging. We wanted to have approximately a post-op outpatient MRI done at 3 months. We also wanted to ensure that none of these individuals had undergone any adjuvant therapy between the time of the post-op MRI and the follow-up MRI. Once we had that exclusion criteria, we were left with 32 patients in our cohort. And please stop me or ask any questions as you would like. So tumor volumes were measured by this Terra-Rucon intuition software, which is some of the software that the radiologists have been using for other studies. Its auto segmentation is done, but then there is some fine manual contouring on the 3 different planes, axial, sagittal, and coronals. Then they have a 3D image overlay to make sure the segmentation was accurate. And the thresholds were 1.5 centimeters for the FLAIR sequences and 1 centimeter for the T2. So as I mentioned, there was 32 patients. We ensured that they were truly low grade. So 65% were astrocytoma and 34% were patients had a diagnosis of oligodendroglioma. The average age was 36.5 years, although it ranged from 22 to 75 years. Slightly more males than females were in our cohort. They were truly low grade. Their IDH status, most of them had the canonical mutation 132H, 37.5. There's 3 patients that was not performed, but I think the pathologists believed that they were definitively oligodendrogliomas and didn't feel like an IDH was needed. There was 1 that was IDH wild type. And the mean preoperative tumor volume was 30.7 or plus or minus 4.6 centimeters cubed. So this obviously looks like a very busy plot, and we'll try to walk us through it a little bit to make some sense of it. So each of these lines is one of our individual patients, so our 32 patients. On the left side, the intraoperative MRI volume, that's the IMRI volume that was calculated, and that was, I believe, 2.17 plus or minus centimeters cubed. Then the post-op, this is the MRI that was taken within 24 hours of resection, and almost doubled. It was 5.47 centimeters cubed. And then the 3 months, which was around, I think, 92 days, it went back down. It was like 3.44. And as I mentioned, we wanted these patients to be patients that we were trying to go for a gross total resection, just because if it'd be too hard to compare each individual patient as a extended resection or anything like that, and to look at the actual volumes. And I think the gross total was around 85% of our patients. Near total was 14 to 15. So as I mentioned, the pre-op volumes were around 30 centimeters cubed, and then the post-op again was like 3.4 at the 3-month follow-up time. So, you know, we were not the first person or first group to show this, but immediate post-op MRIs may not be the best indicator of residual disease or extended resection. And the IMRIs may be a better reflection, or waiting to the 3-month time frame to look at residual disease and extended resection before starting treatment, especially in individuals that are less than 40 years old. We don't want to start anything too early on those individuals. And that, it was a pretty basic study, but hopefully it will help others ongoing. The positive in our study was that most of the time the individuals are getting their preoperative MRI also in the same intraoperative MRI that we end up using. So we're not comparing 2 different types of machines or 2 different thicknesses or cuts. It can be the exact same machine on the exact same patient. So it was not a difference in magnetic strength or anything like that.
Thanks so much, Kristen.
I think this was a great study, and appreciate you joining us. Go ahead, Randy. You've got probably the first opportunity for a question.
Yeah, well, you know, I'm just curious. You know, what is your reasoning? What do you think happens in that 24 hours most likely? Why is the volume different on the immediate post-op versus the intra-op?
I think that you know, despite all of us believing we have bloodless procedures, I think that there is some component of blood and breakdown products that is happening. I think the initial scarring, especially with any of our, you know, Surgicel or fibular components, may change things at least acutely, and then within the 3 months time frame, those may equal out over time.
Yeah, so you don't think there's a component of, you know, I don't know, mannitol or brain shrinkage intraoperatively that they're swelling postoperatively in the, you know, periresectional kind of edema? You think it's mainly scar tissue for the most part forming?
Yeah, I believe so, because we do use mannitol pretty much for all of our procedures. Probably all of those patients end up having mannitol, but I don't think that necessarily would account for the edema seen around the resection cavity.
Yeah, I'm going to ask you a slightly different question, which is that, and this came up on an event I attended over the weekend, and how generalizable do you think that this finding is? In other words, this immediate postoperative MRI, you did a study focusing on low-grade gliomas. The session I was at over the weekend was about pituitary adenomas. If we are not going to be doing, and we have an intraoperative MRI, not a 3T, but a 1.5T, and we almost always get scans after we're done or nearly done the resection. So it's wonderful to have it, but I wonder how much it's really making a difference, especially if we're not doing adjuvant treatment in that first, 6 to 12 weeks afterwards. What are your thoughts, sort of more broadly? Does this have greater ramifications?
Yeah, you bring up a lot of points that we discussed on our case conference here at MD Anderson, and also that was brought up as we were finishing up this manuscript. So, and talking to Dr. Elder afterwards, it's, maybe you don't necessarily, if you've done your intraoperative MRI, you feel like you've had a good resection, you're not concerned that you're going to have a hemorrhage. Maybe you just do a CT and then you wait, right? Like maybe there's no reason to have a patient pay for or undergo an additional MRI, especially, after a long procedure.
And oftentimes under anesthesia,
Correct.
Right.
Correct. Or, under anesthesia and or needing to be further medicated that may change your exam overnight and cause all sorts of other additional headaches.
It definitely, I think it depends on the pathology type without a doubt. And I'm sure, obviously pituitaries are going to be different than low-grade glioma. It's going to be different than something else. Your time point, what interests me is the 3-month mark. And I'm curious if you had any data at the 1-month mark. I think a 4-week scan is more kind of common than, a 3-month scan.
Yeah, no, that's a good point. So we base that on, how our neuro-oncologists were ordering them. They almost all seem to have a 3-month. Some of them had a 1-month, but it wasn't consistent enough that we could have been able to look at that time point. But I think that would be a really, especially if it's someone that you're concerned about, I think a 1-month would definitely be advisable. But yeah, we did, unfortunately, we didn't have that. If we had more times, it would have been interesting to look at that earlier. But in terms of like low grade versus pituitary or even higher grades, I think that some of these, like Dr. Sheehan was talking about, these seem like this might be a phenomenon that we're seeing across multiple pathologies.
Yeah, anyone with an image, I guess, there's risk for it. I'm curious about, I'm curious about the cost dynamics of, just using that intra-op and then, kind of eliminating that intermediate MRI. Any insight into what, kind of cost savings there would be if you skip that kind of 24-hour one? Yeah,
that's a good question. And I always feel bad giving this answer because it seems like if I was a patient that I'd be frustrated with a physician that doesn't know the cost of an MRI, but I feel like it's got to at least be between 5 and 10. If I, was playing Price is Right rules, I'd probably go with 5. But yeah, definitely there would be a huge savings, especially if it's not going to be something that is an actionable image that you're going to do anything off of.
Well, yeah, I don't know. Is it a huge savings? Because an intra-op MRI is not cheap, and you need the tech, you need OR staff, you're using OR time as well, but it's obviously built into the actual procedure time and code. And so. Right.
And especially if you're if you truly believe that you have it all, it's more confirmation. But that being said, if you're going to be doing that, and I feel like if that's becoming standard of care, then that people will want that.
So have the folks at MD Anderson adopted this technique? Have you guys changed clinical practice based on this?
I have mentioned it on conference, but I would never say that it's, I feel like most of the time they end up getting IMRI anyhow.
Yeah.
Yeah. One of these things though, as Randy said, it's not just the cost, but it's, whether or not, it's the cost of the patient or the cost of the system. And particularly if the system doesn't get reimbursed for that added expense, it does represent a challenge. And obviously when you do things in the OR, like the ER, they tend to be very expensive places to get diagnostic imaging, right? And so, and then the other thing that's interesting, I think, about it raises sort of a point we've been feeling a little bit of, and I've seen across other centers, is just this desire on the part of a hospital or health system to look at practice variations. So, maybe I get an intraoperative MRI and then I get a scan at 6 weeks, but my colleague down the hall gets one at 8. He never gets an intraoperative MRI, but he gets a scan at 1 month or 8 weeks or two months out. So I think that it's these kinds of studies that may help us to based upon evidence, to bring some to bring some decrease in the practice variations, and probably rightfully help to contain some costs and expenses for patients. Where we can all come together and say, well, we may not need one, right, intraoperatively on certain indications, and I'm curious if either of you have seen a push by your health system administrators to decrease these variations, especially when they add cost without, perhaps the benefit that we thought they might.
From writing this article, one of the authors is a neuro-oncologist, Dr. Giglio, who was great on this, as he is with many things, but he was at times ordering multiple MRIs on those individuals where you might see these early post-op changes and concerned that it's tumor. And so now he's reflecting that maybe he doesn't need to get one at 2 weeks and then 1 month and then 3 months, is now seeing that these changes are not necessarily something that necessarily should jump on, but that this has brought light to that.
Right. Randy, and I'm curious, are you seeing any push on the part of your hospital to make a standardization of post-op imaging or other sorts of things like this?
Yeah, to be honest with you, I mean, it's always in the background, right? You always hear this kind of stuff, but no one's made any moves, and we don't feel that much pressure to do it. I don't know whether or not it's a little bit that neurosurgery is a black box, and that the admin doesn't really know what we're doing, or whether or not it's just that they're kind of left alone. But also, just myself being kind of a younger guy in practice, I don't feel much pressure for that at all. But I hear you. There's talk about it, right? It's the chirping always in the background about these things. For the most part, we do subscribe to a pretty standardized, imaging algorithm amongst ourselves. So I think, it just might not be that much of an issue.
Right. And I think it's where there's not widespread variations, there's probably not a big deal, but where there are instances, as Kristen had alluded to, where maybe one provider may be getting some studies because that's what the way they've always practiced or felt, perhaps this is cause for reflection, not just on the part of ourselves, but probably by others who look at the accounting in a different way. So
yeah, absolutely.
Great study. I liked it.
Yeah, Kristen, thanks so much for being a part of it. We can end a little bit early today. It's 4:20. About any final parting thoughts? Is there anything else you plan to do with this, or kind of onward with the research?
No, it's just every so often when we're debating the natural history of low-grade gliomas and are unclear what we should be doing, this definitely is something that's been brought up. So it's nice to have at least a piece of data to hang our hats on, that maybe we shouldn't be jumping the gun and wait a little bit at a time, especially for these younger patients. Especially
since you didn't treat. I mean, 3 months, that's a sizable amount of time without any treatment whatsoever in this patient population, where you see actually really a constriction, if you will, of the surgical cavity from what you can tell. So yeah. Great job. We appreciate you being here. Yeah. Thank you so much. And I'm just one of many people. So I just want to thank everybody else who was part of the study.
Thank you so much for joining us. Great stuff.
Thank you. All right. Take care, everyone. We'll see you next time.
See ya. Thank you.
Bye-bye.
Bye-bye.